Served as the CEO of Spartanburg Regional Health System. I've also led 6 other systems in 5 other states. 2 of those were primary teaching hospitals. I'm the past chairman of the South Carolina Hospital Association and Health Sciences South Carolina. I've been a professor in 3 medical schools and served on the board of the American Hospital Association. I am in support of this legislation. 40 other states allow CRNAs to deliver anesthesia without supervision. All 4 branches of our proud military have always allowed CRNAs to work without supervision. From the field to Walter Reed Army Hospital, South Carolina is a minority of only 10 states, only 10 that don't allow this. That's why we have a shortage of people delivering anesthesia. Our state has about 450 MD anesthesiologists and about 1,350 CRNAs. We also have 2 graduate education programs for CRNAs at USMC and the University of South Carolina here in town. Our neighboring states are very happy that we have not passed this law because you see, those 2 programs are tax supported and many of their graduates go to Georgia and surrounding states where they can practice independently. This makes no sense. 25 years ago, I taught at the University of Kansas Medical Center and ran a system with 8 hospitals. At one point, the entire western half of that state did not have a single MD anesthesiologist. That's a land area over twice the size of South Carolina. And every single juried study proves that CRNA care is identical in quality to the care delivered by MD anesthesiologists alone. Let me say that again. CRNAs and MD anesthesiologist care is identical in quality. And CRNA delivered care is a bit more cost effective. Hospitals and ambulatory surgery centers can save about 25% of their current anesthesia costs by using CRNAs to provide their anesthesia. And how will the passage of this legislation affect our 65 hospitals? Small and medium-sized facilities now have to hire the services of round-the-clock MD anesthesiologists to supervise their care. That costs about $1 million plus per year. It's likely that saving this cost might save 1 or 2 hospitals in this state from closing their doors. On a personal note, since I've lived in South Carolina, I've had 3 cancer surgeries. All of them have been done by CRNAs. I trust them with my life, and you can too. Thank you. I'd be happy to answer any questions.
I have a question. Who orders the anesthesia for the operating purposes? Does the nurse anesthetist do it? Does the anesthesiologist do it? Who orders that medication?
Generally, there's this, who orders the medication in the operating room, or who orders the anesthesia?
Who orders the anesthesia?
When a surgeon's office schedules a case, let's say it's in a hospital, the operating room people who have schedules and they have the CRNA schedules, they will schedule a CRNA for that room and for that operation. Larger hospitals, there might be a team of 4 or 5 CRNAs who do nothing but open heart surgery, and another group who might specialize in nothing but neurosurgery.
So who orders the anesthesia?
The anesthesia in the operating room is ordered by the CRNA.
Okay. Representative Cox?
Thank you, Madam Chairwoman. I want to touch on a little bit of the 40 other states issue. Because y'all keep, I mean, the CRNA keeps saying that, and we keep seeing that, but it looks like it's more of a word semantic kind of thing to me than just no supervision. Georgia defines their responsibility and how it is under the direction and responsibility of physicians who are members of the medical staff. And they also say under the direction and responsibility, but it doesn't appear that that CRNAs are just acting alone. I mean, can you talk a little bit about that? Is there a
Sure.
difference between the word supervision, direction, collaboration?
The 40 states that allow unsupervised by MDAs and CRNA practice accomplish it differently, and you're right, it's a word salad. You'll notice the language that you just quoted from Georgia says under a physician supervision. That means a surgeon as well as an MDA, okay? Some states accomplish it by changing their Nurse Practice Act, which is what is trying to be done here. In some states that are wide open, it's managed by the credentials of the hospital. The hospital medical staff decides who can deliver anesthesia under what circumstances. The federal government pays for a lot of health care through Medicare and Medicaid. They have allowed direct reimbursement for CRNAs in states that opt out of requiring MD supervision. So some of those 40 states just go ahead and opt out of MD supervision with the Medicare program and accomplish the same thing. So those 40 states do it 3 different ways that I know of, and I'm certain that there are others that are just as creative. But in point of fact, the 5 other states where I worked and ran medical centers all had CRNAs allowed to practice without supervision.
But were they still under, I mean, was it still direction, collaboration, or was it just?
It depended on the setting.
Right.
For example, in the Kansas example, in the main hospital, the open heart surgery and neurosurgeries were practiced under team anesthesia. The GI center, there was just CRNAs practicing without supervision. We owned and operated 8 other hospitals, and all of those operated with CRNAs independently. And we had a local large ambulatory surgery center, and CRNAs practiced independently there. What happened was the anesthesiologists could affect care most by running the intensive care units. In a lot of hospitals, your family practitioner can admit a patient to an intensive care unit and treat that patient. Well, they don't do that very often. Anesthesiologists are tremendous at understanding all of the interplay of all of the systems over a long period of time, so they don't have bad lungs due to failing kidneys, and they're great at taking over the care and managing intensive care units, and that's what we have them do primarily.
Are there any other questions? I have a question. Removing the word supervision from the Practice Act as it is written now, what will that mean? Will that mean independent or no specific relationship with the physician?
No, it will allow that to happen, but it won't mean that. As I said earlier, that will be dictated by the hospital medical staff bylaws. I suspect nothing will change immediately. Slowly, smaller hospitals and ambulatory care centers may allow CRNAs to practice independently. But it is finally up to the hospital as to how they will organize the delivery of anesthesia. Changing this law will not change that. Hospitals will still have the ability to organize anesthesia how they wish. And that cannot be taken away. That's by your commission and Medicare standard.
So removing the word will not make the CNAs independent?
It can. It will allow hospitals and ambulatory surgery centers to make that decision. But doing it will not automatically cause that to happen. That will be done by medical staff bylaws.
The next question I have is, I've heard, and not heard it today, but I've heard it before, that if we remove the word supervision, that it's going to help rural areas. Can you explain how it's going to benefit rural areas?
Yes. Most of the 65 hospitals in South Carolina are small and rural. Requiring MD supervision, as this state does, means they have to contract with, attract, find a group, hire, by hook or crook, anesthesiology round the clock. And that's at least 3 doctors on call to supervise the CRNAs. This would allow rural hospitals, their medical staffs would have to make that decision after you pass this law. But this would allow those rural hospitals not to have to require MD supervision so that CRNAs could practice independently. Anesthesiologists make something north of $300,000 a year. That's the national average. This would allow that hospital not to pay that 3 doctors times that amount of $1 million or more for MD supervision and not affect the quality. It's going to allow 1 or 2 hospitals that would close to stay open. It's a big deal.
Now, there was a CNA that testified on last week that she was the sole person in her setting administering the anesthesia, and there was no anesthesiologist there. Is that permitted under the law as it is written now?
There seem to be circumstances where it's going on. There's an ambulatory surgery center in Aiken that does. Certainly all the military bases that are in our state practice that way. In a lot of outpatient settings that do not have medical staff bylaws, like a dentist's office or an ophthalmologist's office or a plastic surgeon, they would allow a CRNA to practice independently and do.
But if they are doing that, regardless as to circumstances, is that going against the law as it is written now?
No,
It is not.
no.
So it can operate like that.
I suppose it can, but as a hospital administrator, reading the South Carolina law with that word required supervision in there, I would not make any changes in bylaws because I wouldn't want to defend that in court. I get sued a lot.
Well, she
But
didn't say
removing
that
this
it-
word would allow the hospitals to make that decision.
I think this was a different setting other than a hospital.
Yes, it probably was.
So if it's a different setting other than a hospital, it is permitted.
Yes. Any place without medical staff bylaws would be permitted. Any place with medical staff bylaws would be reluctant to allow this to occur without a change in the law in this state, as it does in other states.
Are there any other questions? Representative Gilliam?
Just quick, sir. Tell me, when would there be a situation when anesthesia was needed that there would not be a physician?
I can't think of one.
Me either, no, sir.
I mean, there's always a surgeon doing something to the patient that requires sedation. So, yeah,
Be a
you're
dentist
absolutely
or
right.
Whatever it is, yes, sir.
Unless you're Michael Jackson. Now that's different.
Yes, sir.
There was a doctor there.
That was me. Thank you for your patience.
Are there any other questions right now? We're going to hear from Dr. Ken, is it Klaxman?
Yes, thanks, Madam Chair.